الرحيم. السلام عليكم ورحمة الله وبركاته. جميعا معكم دكتور علاء ياسين من سياتل واشنطن. شكرا دكتور مازن، شكرا طب الأسنان مباشر على دائما الاكتيفيتيز يلي بيقدموا لنا إياها. الحقيقة إنه الجهود مميزة، وبارك الله فيكم جميعا. أنا علاء ياسين. أنا تخرجت من كلية طب الأسنان بجامعة حلب، وتخصصت جراحة وجه وفكين بمشفى دمشق، وتخصصت بجراحة اللثة وزراعة الأسنان بيونيفرسيتي أوف واشنطن هون بسياتل. أهلا وسهلا فيكم جميعا. بدنا نحكي اليوم عن موضوع كتير مهم وجديد، حكينا عنه قبل سنتين تقريبا، بس هالمرة بدنا نعيد نحكي بشكل شوي مفصل مختلف عن الوضع يلي ناقشناه من سنة. إذا عندكم أي سؤال أو أي استفسار feel free to reach me out. So the presentation will be in English. I wanted just to make a quick introduction. I'm Dr. Yassin. I am a dual trained dentist in both oral surgery and periodontology. I live here in Seattle, Washington. I'm an affiliate faculty with the University of Washington, and I am the course director of the clinical implantology A to Z here in Seattle. The presentation today will be talking about the digital design prefabricated bone blocks, which is something new, a new technique that we have been using for the last couple of years. And I wanted to share this with you at the online with this live stream. Please, if you feel there's any question, feel free to reach out either with the live broadcast here or down the line and in the email, or visit my website. I live here in Seattle, Washington, a beautiful city, amazing city at the very end of the northwest of the world. I love Seattle. I'm proud to call it home beside my two favorite cities, Damascus and Aleppo in Syria, who are my first home, and I always have huge love and passion to them. So those are my three cities. This is home. As I mentioned before, I am the course director of the clinical implantology from A to Z. It's a full year program heavily oriented on clinical and hands-on here in Seattle. I know that we have a lot of audience from inside the States and from abroad. We have achieved a great achievement last year that we are open for out-of-state and internationally trained dentists to come and continue their education in implantology. So if you are interested or if you have any question about it, go to the implantologyatoz.com and you'll have all the information needed. The overview of the presentation today is talking about bone graft and the osseous augmentation in implant dentistry, why to do bone grafting, the classification of ridge defects, the diagnosis of bone and loss, bone loss and the radiographs needed there, principles of bone augmentation. Our bone blocks are the gold standard still, and we'll touch base a little bit about the autogenous bone blocks when we present the couple of cases probably about digital prefabricated allograft blocks. Why do we need bone grafts in implant dentistry? After any tooth extraction, it is evident that we start to have bone remodeling and bone resorption in the area. Carl Misch in 1993, he was a very nice study showing that there is 40 to 60% of width of the ridge will be absorbed after the extraction. The legend, Dr. Brandmark, the master who taught us a lot about implant dentistry, had a really important concept when we start our implant practice. It is the bone to implant contact. Whenever we need to put an implant inside the bone, we must consider two main things. One is the bone to implant contact, and second is the initial stability. Of course, nowadays we need to think about restoratively driven implant dentistry. Think about the platform of the implant, where it's going to be before moving forward to place the implant inside the bone. After the bone resorption, we'll have some ridge resorption. After the extraction, we have some ridge resorption, and there's a classification for the ridge, a lot of classification for the ridge deficiency. Schwartz in 2004 had like this detailed classification that will give us class 1, 2, and 3 in the position that we can place an implant either with minimum or no simultaneous bone grafting around the implant. Class 3 will have a little bit more bone grafting because of the deficiency here, and a class 4 will have three-dimensional bone resorption or bone deficiency, which will require the bone to be rebuilt in 3 dimensions. So we have a lot of other classification. We need to understand the bone available for our implant placement before even starting the implant surgery. Luckily, nowadays we have a lot of digital advancement that will make it easier for us to plan the case and to discuss with our colleagues an interdisciplinary approach where we can discuss as specialists, general dentists, and prepare the case for the best service for our patients. With the CBCT, with the DICOM files, the superimposing with the STL files, the possibility of integration in a lot of softwares, great softwares, we will be able to go ahead and do the restorative treatment planning even before thinking about the bone. Here, when we have like intraoral scanning, we can plan and even design the restorations before even thinking about the bone available. We want to achieve the point where we plan the case from the last point backward. So we need to know what's the final restoration there, and then from there plan our cases for implant placement. As you can see, whoever has been doing implant dentistry for a while know that we can do this three-dimensional study over a CT scan, and we can locate our implant to the best ideal position that will allow us to the best restoration at the end. So this is the big concept. We need to know the best ideal restorative position for the restoration before placing our implant. Which will make our life easy, which will make our restorative dentist life easier as well. This is another example of how can we decide if we need bone grafting, with simultaneous implant placement, or in 2 stages where we need to rebuild the ridge and put the implant. We understood that there is mainly one ideal position for the implant platform here that will make it in the best restorative position for our final restoration. So when we place our implant digitally, virtually, we will be able to define how much bone already absorbed and how much bone do we need to rebuild around our implant. Do we need to do it in 2 stages or 3 stages? As you can see here in classification class 1, we have only horizontal bone resorption. In class 2, we have vertical bone resorption. In class 3 here, we have both horizontal and vertical bone resorption, which is a 3-dimensional resorption that requires 3-dimensional reconstruction of the ridge. It's one of the most challenging cases in implant dentistry when we need to rebuild the bone in a vertical dimension. Through the years, and I've been in oral surgery and periodontics for almost 19 years right now, I was able to build a better understanding for how to build bone. And I summarized my knowledge in 9 steps or 9 principles. I called it the tent example. Whenever we want to build any bone for implants, whether it is simultaneously with the implant or in 2 stages, we want to remember those 9 principles of tent example. We need to reflect into 3 main categories: graft related, barrier related, and recipient related. And all those concepts and principles, they are connected to the tent shape that you use when we go for camping. Let's go ahead and see what are the graft related principles. Number one, stability of the bone graft. We can't really go camping without any stable tent. Space maintaining, no collapsing materials or membrane to help us with space maintaining above the bone graft. Same on the tent. We need this middle post inside the tent that will help us with keeping the space maintained and give us some space to work. Material with osteogenesis property. We need some kind of bone graft and bone clot to get some kind of bone. So sometime we even be able to grow some bone with only some blood clot underneath our contained area. The barrier related principles. One is isolation from the surrounding tissue. We need nice barrier. I like to call it the blanket over our bone graft, similar to the tent. Perfect seal from the outside effects. We need to have a primary closure over the bone graft to help us with the osteogenesis process. Again, similar to the tent, we can't really live in a tent that it's open, has open spots there, here and there. Contained environment, we need to have a membrane stability and closure over the bone graft to help with bone building. And again, it's space maintaining, no collapsing material or the membrane. This could be achieved by the membrane itself, similar to the tent concept when we go for camping. How about the recipient side related principles? We need blood supply, nutrition to survive the bone graft, similar to the tent. We can't really go camping without bringing our food and water, or have somebody delivering this to us so we can survive our camping. We need a firm contact with the underlying base, rigid contact with the bone that will make the blood supply, the stability, all the above a little bit easier. Similar to the tent, we need stable, nice, flat ground that will make it easier for the stability of the tent. And finally, we need a clean environment. No infection, no bacteria before doing our bone graft, so the bone graft can survive. So this is probably one of the most important slides in my whole lecture, and even in my courses when I give the bone graft topic, I split it into 2 different level or categories. The beginner level bone graft course, which will focus only on simple ridge preservation and ridge reconstruction process, and the advanced course, which I teach more advanced sinus lifting and more 3-dimensional ridge reconstruction. Both sides, we discussed those nine principles. So if you go out from this presentation today with only this slide, I'm pretty happy. Let's move on and see what are the situations in implant dentistry that we do bone grafting and around implants. Either we do bone grafting at the time of the extraction, we call it ridge preservation or socket grafting, or we do at the time of implant placement simultaneously. If we have mild to medium bone resorption around the implant site, we can put the implant and do some simultaneous bone grafting, or after the extraction, if we had huge resorption either by vertical, horizontal dimension, that will make it a little bit more complicated to rebuild the bone before even thinking about implant placement. I want to really touch base with the amount or the classification of bone graft materials we have. We can use autograft, which is from the same patient. Usually, autograft is the best material to provide osteogenesis and bone building. Allografts, it's provided from human, from donor bone, from other donors. Xenograft, it is provided from animals, from other species, and alloplastic materials, which is the synthetic bone graft. All of these, they are, we can provide them with either particulate shape or with block shape. That will make it a little bit more simple for us to choose which route should we go with bone grafting. Why do we have all this different bone graft material, and which one is better? And it's a long discussion. It's not the topic of this lecture, but I wanted to show what are the mechanism to build bone through this different bone grafts. We have three main mechanism to build bone. Osteogenesis, which means that the bone graft itself has the ability of recreating and building bone. Only the autogenous bone graft, which is from the same patient, will provide us with this property. Osteoinduction, which means that the bone graft will enhance the surrounding recipient site to rebuild the bone. We see this in autogenous bone graft with allograft, the DFDBA. Osteoconduction, which means that the bone graft will act like a matrix. We put it there and the body will use it as a matrix to rebuild the bone. All the bone grafts, autogenous, allograft, the xenograft, the synthetic bone, will have this characterism in bone building. Moving on, this is the idea where we want to put the understanding for our bone defect, what's the amount of bone we want to build, understanding the mechanism of bone building, and those 9 principles for bone building as well, is the way that we need to understand how to proceed with our bone grafting materials. Well, we talked about stability and space maintaining. We talked about all these 9 principles, and let's see through the years of bone grafting what kind of tricks we've been doing or we've been trying to achieve all these 9 principles. 1, bone blocks. From autogenous bone blocks, this is the golden standard. We take a block from the chin, from the ramus, extraorally, to provide this space maintaining stability and all the 9 principles that we discussed for bone building. We have the membrane tacking, which will allow us with providing more stability and also space maintaining. We have the trick of doing a tenting screw that will give us space maintaining over the bone graft. Stabilizing sutures. A lot of colleagues, they've been describing techniques of suturing that will stabilize not only the membrane, but stabilize the bone graft, the particles underneath it with the bone graft. We went the extra mile 10 years ago, and the industry allowed us to use the polylactic acid membranes, which is space maintaining hard membrane, but it is resorbable, so there's no need to come back to remove the membrane, which is also will mainly focus on stability and space maintaining to build our ridge. Titanium mesh or titanium reinforced membranes with the PTFE membrane also are ways to play around the space maintaining and the stability for our bone grafting material. So you see, we are rambling around trying to find the best way to build bone, and probably this more advanced techniques are more targeting the 3-dimensional, more complex cases where we need to build more bone for implant placement. So eventually we have a lot of complications. We need high surgical skills. We need to choose the right material, a lot of possible infections, a lot of possible complications of exposure of the membrane on the PTFE membrane or non-resorbable membranes like the titanium mesh. That will allow us to say probably going back to blocks is the gold standard for bone building is the way to go. This is why you see a lot of time we rethink ways of doing blocks more than particulates and do membranes over it. Let's see here with this 9 principles that we discussed what works best, what works less for bone building in between autogenous blocks or autogenous particulate graft, or in general blocks and grafts. For stability, absolutely, the blocks work way better than the graft. We can stabilize this blocks with rigid fixation via titanium screws and put it inside the bone. Space maintaining, also the bone blocks will give us more control over this. Osteogenesis effects, it is the same, probably in the particulate, it's a little bit more contained with the barrier. We can achieve this contained environment with the bone block in a better shape. Primary closure over the graft, it's a little bit easier to achieve this primary closure with this nice blanket of soft tissue with the particulates graft. The blood supply could be the same if we chose the right materials and the right technique to do our bone blocks. Firm adaptation with the base. We have some challenges, especially when we do the autogenous bone blocks, to adapt the block into the bed of the recipient site. While in the particulate, we have nicer adaptation between the bone particles and the bed underneath it. Infection resistance, if we followed the good measures of surgery, should be the same on both sides. This is like a really quick reminder about what can we do with the autogenous bone blocks here. Lateral, maxillary lateral, we have moderate bone loss here. We chose in this case personally to go with ramus bone block. I go to the ramus, you study the IA end position, make sure that everything is good and safe. Use your full thickness flap to expose the area and harvest the bone. Reshape the bone block that you have. You can see that we have both layers of cortical bone and cancellous bone and the autogenous bone. Reshape it so it can be adapted into the place, and then prepare the bed site or the recipient site with some decortication to enhance the blood supply and the blood flow into the area, and stabilize the bone with some screws. And so one of the things that I really need to mention, whenever we use a block, it's recommended to have 2 mini screws intact or connected to the bone block to prevent any possible rotation in the bone block. But you can see that there's some kind of really challenges to do this adaptation between the block and the underlying bed. So this is why a lot of time you see oral surgeons, they say, or periodontists as well, they say, like, whenever I go back to put my implant, I see fracture in the bone block, just because there's not enough adaptation between the block and the recipient site. In this case, we had pretty nice remodeling and connection between the block and the recipient site as well. And the time of implant placement, we have like nice thickness that will allow us to go ahead and do the implant placement with enough bone there. So as you can see here, it's really important to mention that firm adaptation with the base is one of the most important challenges in autogenous bone blocks. Beside, of course, the advanced surgical skills that we need to achieve and to practice before collecting bone from the chin, from the ramus. Overall, blocks seems to be doing the job more than the particles. This is why you can see that we have the blood supply. If the bone block is really thick, the blood supply concept is really challenging. The rigid stability is really important with the blocks, and the adaptation between the autogenous bone block and the recipient side is also a challenging way to achieve nicer bone building. This is why several years ago, Dr. Fuad Kuri in Germany thought in a different way. We're using the blocks in the way that we need more space maintaining and stability, but still we have problems with this adaptation in between the bone block and the recipient side. We have better adaptation with the particulates. And he came with this genius idea of let's use the autogenous cortical bone from the outside to achieve the two main goals of the bone blocks in stability and space maintaining. And let's use our particulate, either autogenous or mixed bone grafts, underneath them to rebuild the bone. This is a case from my friend Dr. Gluckman about Cori technique for bone rebuilding, which has been a great experience for the industry and to rebuild complex three-dimensionally absorbed or atrophied ridge. I mentioned my course before. I have a big line of guest speakers that always we hit on topics, every single topic in implant dentistry that will allow us to understand everything from A to Z, exactly like the name of the course. The guest speakers, they are different backgrounds with general dentists, prosthodontists, periodontists, and oral surgeons as well. That will make it way more advanced for doctors to go ahead and learn from the best in the industry. The program is a full 1 year program, but it is open as well for individual courses. So if somebody really are interested in more advanced bone grafting or soft tissue grafting, please go ahead and take a look at this website, and it's going to be a lot of good information for everybody. So now we understand the bone grafting technique and what's the pros and cons for particulates, bone blocks, autogenous bone, and we understand the challenges that we have for autogenous bone blocks. This is why we have this new method that I've been utilizing for several years right now, which is the digitally designed and fabricated bone block. And mainly, instead of going to the same patient and collect bone block that will give us some challenges with bone stability and the adaptation, plus the morbidity of having a second incision and the same patient, we are able, using this technology that we discussed, to use the three-dimensional CAD/CAM technology to design the bone block that we want and to prefabricate this bone block from allograft material. That will make it easier for us to rebuild the ridge in 3 dimensions, use this bone block as a Lego, put it on the bone, stabilize it in a couple of screws, and move on. We are already providing osseo-induction and osseo-conduction materials with space maintaining and with stability as well. So it's individually designed allogenic cancellous bone block. Maximum dimension we can mill so far is 13 millimeter by 13 by 23 millimeter. This is what the technology is allowing us to do nowadays in 2020. The bone blocks, the 3-dimensional bone block that we can mill, will provide us with advantage of horizontal and vertical ridge augmentation in the aesthetic zone, and the complex 3-dimensional reconstruction of the ridge. So it's pretty much a nice way to utilize all the advantages in the bone blocks minus the morbidity of the second surgery, plus the advanced surgical skills that is needed. Still, we need to have basic surgical training, of course, to do this kind of bone blocks. Whenever we have our bone block fabricated and designed for us, in the time of the surgery, we need to go with the flap preparation and reflection, which is soft tissue preparation is probably is the most important thing in a successful bone graft. Positioning of the block over the defect, screw fixation over the block, smoothen the edges, and make sure we have nice adaptation between the block and the surrounding uh, space. Particulate grafting materials to fill up any gaps between the block and the recipient side. Put a barrier membrane. We need here only a resorbable barrier membrane to contain everything, and achieve a primary closure, the nice soft tissue over the block with a tension-free flap closure. So this is the step-by-step performance for any surgery and the digital bone blocks. Let's see this clinical case that it's really a way to understand what we're talking about in the digital design and prefabricated bone block. This is Maria. Maria had a trauma on the anterior area. She has really severe bone loss into the centrals and laterals front maxillary area. Pretty challenging. She's a young, beautiful lady, and she came to me asking to have implants. She's just tired from her removable partial denture. If you can evaluate the ridge, you can see that we have both horizontal and vertical bone resorption, which will put us in classification 3 for the ridge deficiency and make it hard for us to rebuild the ridge three-dimensionally without using some advanced techniques. Mainly either to use particles bone graft with some nice space maintaining and stabilization like non-resorbable membranes, or to go with the blocks, which is going to be either autogenous bone blocks, Corey technique with the plates and the particulate bone, or now we have this technique of three-dimensional digital bone blocks that it is prefabricated for her. This is how we start the whole treatment planning. As we discussed before, you go to the software, digital work, and you plan your final restoration before even thinking about your implant and your bone. And from there, you go back and you put your implant in the right position that follows the ideal restoration over the implants. After you're satisfied with the restoration, with the final crowns and the position of the implants, we build some bone around the implant. We know that there's some essential principles in implant dentistry that provide us with at least 2 millimeters of bone surrounding the implant to be supported. And we need at least 3 millimeters between each implant, titanium and titanium. We need at least 1.5 millimeters between the implant and the adjacent tooth. Whenever we achieve these dimensions, we kind of design the bone block, as you can see, that will provide us with enough support for the implant and a nice bone graft that even with the remodeling and the allografts probably will remodel in 20-25% of in volume, that will stay providing us with nice bone block and bone support into the area. So eventually, as you can see, we will be finalizing the whole treatment plan with having a nice block digitally designed, and we are able to take this design out to our milling machine for allografts, donor bone, and then mill this bone out from our donor bone as an allograft block material. And this is the final result. This is how we ended up with the design, and this is the fabrication. This is how we utilize the CAD CAM, which is computer aided design and computer aided manufacturing for the bone graft in the area. Eventually, we have the same, no error in the milling. It is cancellous bone. It's helpful for us to go there and do it as a Lego into the space, make sure it's stable, space maintaining. All the 9 principles of bone building will be achieved simply. Reflection of full thickness flap. We need an extensive bone flap here thinking about the final step of doing tension-free flap and the primary closure over a huge amount of bone. So now remember, this kind of topic is for advanced practitioner in implant dentistry. And you know, whenever you add more bone, either by particulates or bone block, you need to get more soft tissue volume to uh, compensate against this bone volume that you put over the bone. Meaning that you have the gingiva and the soft tissue already attached to the bone firmly, and it is nicely positioned there. And when you reflect the flap, the same amount of the gum is there while the bone will be bigger. So you need to achieve primary closure. You need to make this flap longer. This is what we call it, the flap dissection into it. This is why I stopped for a minute and I talked about how important it is to have nice quality of soft tissue at any bone graft case. Before even thinking about the bone, we need to think about the soft tissue. A lot of time, I go ahead and I rebuild the gingiva or the soft tissue with free gingival grafts to make it nice, better coverage, nice blanket to cover the bone graft before even jumping into the bone surgery. In this case, full thickness flap, reflection, we see exactly the bone quality there. We go ahead with this Lego shape bone block, we put it in there. As you can see, it's simple, straightforward, three screws placed, and eventually you can expect 20-25% of remodeling for this bone block. So we're losing some of the volume. This is why you can see that there's some kind of challenging shape, big shape into it. There's still some micro gaps around the bone block that will allow us or make us put some particulates there. We need to open spaces between the bone block and the adjacent teeth to allow for some soft tissue healing to go and grow into the space. So we need to do some adjustment before finalizing the whole case with nice coverage with primary closure and tension-free flap. And honestly, this is the most important step in the any bone grafting. We need, if we did all this job of the work and we did not really finalize it with nice closure over it, with good quality of soft tissue, nothing's gonna work. So spending some time planning for this and spending some time preparing the flap with some flap dissection, flap brushing, or either even scarring for the periosteum, that will make it easier for us to do our primary closure. Placement of the resorbable membrane over the bone particles, as you could see, and the bone block, and then starting our primary closure after working on the flap. Make sure that the flap is big enough, and eventually make it three layers of closure with horizontal mattress sutures at the very base of the flap, following with the second layer of horizontal mattress suture on top of it, and finalizing the sutures with some kind of small interrupted sutures as well. This is how we end our first surgery to rebuild the bone. And as you could see, we are able to achieve, even if we have a big, huge volume of bone grafting underneath the soft tissue, we will be able to eventually to go and do primary closure and with a tension-free flap. This is the final flap closure over the bone graft. It's not an easy task. And you can see in 2 months of healing, we have the screws already there. We have the bone block already designed and nice stabilized and designed in the way that it is ready for any possible remodeling. And in 2 months healing, you could see that there's nice primary closure. The attached gingiva is intact. You could imagine that there's some coronally position of the mucogingival junction, just because we coronally advance the flap to cover all this bone block that we have. In 9 months of healing, to allow the bone block to heal uneventfully, you could see that we have nice ridge, better than what we started with. We are able to plan our implant surgery in the way that will put it in the better aesthetic, better functional way to this young lady. From there, we just want to try to design our implant placement. And in this case, we were fortunate enough to have enough space to do 3 implants for 2 laterals, 2 centrals, and a lateral in this space. On the CT scan, you could see that we planned things in the way that we have 2 millimeter of bone surrounding the implant. I already decided to go ahead and do zirconium implant in the place to give us the maximum possible aesthetic results for this young lady. And as you could know, with the second stage surgery after 9 months of healing, we probably have like 20% of bone resorption, especially at the body of the bone block. But eventually, the thickness of the bone of the ridge that we achieved is more than enough to place our 4.1 millimeter implant and 3.3 millimeter implant at the other side. That will make it more predictable, and it's more aesthetic and functional into the area. The next step in our implant placement is to remove those screws, the rigid fixation screws. And you can imagine that the screws will be in the way of our osteotomy and implant placement. We cannot start our osteotomy before removing the screws. The moment that we feel the bone graft is ready and good to go for implant placement, we utilize our guide, the computer guided surgery guide that we already fabricated, to not only guide our osteotomy inside the bone, but also to guide our implant placement, so we can put our implant in the best 3-dimensional way possible. We need to have the implant platform and the best restorative position as well. One of the things that I always want to mention when I use my guided my guides for surgical guided implant placement, that we need to recheck the guide and double check and triple check the guide again and again, even before doing our first osteotomy, to understand, is there any error, is there any problem, is there any issue into the guide before placing our burr. One of the issues that we need to spend more time to do it is to the irrigation. The guide could prevent the irrigation from the handpiece to reach the area where we do the osteotomy. So I always ask my assistant to provide extra irrigation from the apical portion of the guide to make it easy for us to do some kind of safe bone drilling. After positioning the implants and do the osteotomy, make sure that we have enough bone quality, understand what's the under drilling that we're doing. This is our zirconium dental implants that will provide us with maximum possible aesthetic results into the place. The zirconium is a metal implant, but it is white metal that will it's been utilized here a lot, especially in the northwest here of the states. We've been using it a lot, and the goal of trying to shift into zirconium implant mainly for aesthetic reason, and second because we've been seeing a lot of periimplantitis cases going around for the last probably 20 years, and honestly we have a lot of protocols to treat periimplantitis, but it's still so challenging, and we know it's more challenging for us to deal with periimplantitis in the aesthetic zone, especially in the aesthetic zone. We have a 3 days course of complications in implant dentistry that will discuss periimplantitis and different protocols to treat periimplantitis, especially with titanium, pure titanium implants. I'm mentioning this because zirconium implants could be, we don't know a lot right now, we need more research and studies, could be one way of going around the periimplantitis and get nice aesthetic results and less periimplantitis into the place area. 3 implants in place. We place the 2 pieces implant, zirconium implant in place. And as you could see, we have the technology, the industry right now allowing us to do implant placement, the zirconium implant placement. It is 2 pieces, which is the body of the implant inside the bone, and we have the ability of attaching the abutment, zirconium abutment, into a zirconium implant. Unfortunately, so far, the smallest diameter that we can do zirconium implants is 4 mm. We can't really do it thinner because it's going to be really less durable. Whenever we need to do less diameter or less size, we need to go with 1 piece zirconium abutment. This is why you see that in the lateral area here. I ended up doing one 3.3 mm implant, zirconium implant, which is the 1 piece, providing us with nice healing around it. Primary closure over our work, and then try to wait for another 3-4 months for the healing to be achieved, and finalize the case with nice, good soft tissue and hard tissue around the implants. So this is the summary of the whole thing, that we want to get all the 9 principles of bone building. We know that we need stability and space maintaining. We have some challenges in the autogenous bone blocks for stability, for the firm adaptation between the bone block and the recipient side of the base. This is why we have this technology helping us to do some kind of prefabricated bone block that will help us with rebuilding the ridge 3-dimensionally and safely, without having any problems in either the adaptation, the second surgical site, the morbidity in general. I hope that I covered all the concepts and the bone blocks. And for the doctors who've been watching either here in the States or down in the Middle East or all over the world, I hope everybody is taking something from this lecture. So if you are in the beginner level, probably you got the classification and the understanding for what's the necessity to go ahead and do bone grafting and implant placement. If you are in the advanced level of implant dentistry, it's also good to understand what are the principles for bone grafting. A lot of time we need to go back and do some refreshment for our skills and our knowledge. Not a lot of people I know, they are utilizing this 3-dimension digital bone blocks. It's still something new. We need to have long-term study and research to see what's exactly the longevity and the prognosis for this cases. From my experience, and I did probably 10 to 20 cases of this, in my experience, it provides us with a great service for our patients, and will still get better, especially with the advancement in the CAD/CAM techniques that will help us to build the ridge in the best way. Finally, this is our class of 2020-2021 for clinical implantology from A to Z program. It's a full 1-year program here in Seattle, Washington. We start in September of every year and we finish in June of the following year. This year we have 15 full-time doctors. The course is open for individual courses registration as well for another 10 doctors. It's a highly clinically oriented course. We meet once a month for 3 days in the weekend, and we do our seminars with a huge amount of a lot of guest speakers, very highly qualified. Eventually, we do surgeries on Sunday. Doctors, they perform surgeries as well. And as I mentioned before, this year we were very fortunate with the Washington Academy of General Dentistry to be able to get the Washington State green light for us to accept doctors from out of states or internationally trained dentists to come and to be trained with our program. So that's it. This is my presentation for today. I hope that I covered all the basics and advanced topics and bone grafting in general. It's a huge topic. Usually we discuss this through 3 days of talk, and absolutely it's nonstop, and it keeps going more advanced and more with all the technology that we're having. So please feel free to reach out if you have any questions, if you have any comments about the lecture, if you want any literature of what we mentioned. Feel free to reach out either by email or this is the social media. Thank you again. I hope you all stay safe and healthy, and I will see you soon, very soon, hopefully. This is Dr. Yassin from Seattle, Washington, and it was my honor to present about the digitally designed and prefabricated bone blocks in implant dentistry. Thank you so much and have a great day.